Yesterday, we saw a huge jump in the coronavirus recoveries. Discharge figures, like we have 5,526 cases all at once. Today, 399 recoveries have been recorded, with 290 new cases taking Ghana a total of COVID-19 cases to 14,007 cases currently. So active cases stand at 3,449 cases. Recoveries at 10,473. And 85 deaths. So we have 15 more deaths. The Ghana Health Service is not giving a breakdown of this figure. Hopefully, we'll get answers today and other figures from the Ashanti region. Indeed, we have been inundated with many questions from the public on this. So many have expressed suspicions, and you've been talking. Ghana Health Service says it has revised its discharge policy. We have the Deputy Minister of Health, Dr. Bernard Okuboi. He's here to answer some burning questions from the public. Yesterday, the NPP successfully organized the parliamentary primaries, but many disregarded social distancing protocols. Seeing what we've seen and what we know, are we likely to see a surge in coronavirus cases? We have a virologist, Dr. Augustina Silverking, to help us understand this situation. And with many health workers being infected, is there a breach at Ghana's front line against COVID-19? General Secretary of the Ghana Medical Association, Dr. Justice Yangsin, is also my guest tonight and will give us some answers. We are live on the Joy News channel, which is free to air on all digital platforms, DSTV channel 421, GoTV channel 144, YouTube. We are on Facebook and Twitter. Our radio audience will join us at the top of the hour 8 when we also take the presidential address from the Jubilee House. It's update number 12 as our final year SHS and Gold Track students go back to school starting tomorrow as part of the easing of restrictions of phase 1. Welcome to Beyond the Lockdown. It's about you. It's about me. So let's get interactive. Welcome once again. And thanks for staying with us once again. It's time to introduce to you my guests for tonight, the Deputy Health Minister, Dr. Bernard Okuboi, busily scribbling a lot of things down, is my guest tonight on Beyond the Lockdown. Also, joining me in our makeshift studio also is Dr. Justice Yangsin, is the General Secretary of the Ghana Medical Association. And joining me via Zoom is Dr. Augustina Angelina Silverking. He's a virologist at the Kumasi Center for Collaborative Research. Welcome, lady and gentlemen.
Thank you very much.
Welcome, Dr. Bernard Okuboi. I hope you're doing well. Congratulations once again. You went unopposed. You were acclaimed yesterday during the primaries. Did you notice the videos and the footages that came across the country following the organization of your primaries? No social distancing protocol thrown out of the window. Is that what we're supposed to expect?
Sometimes I get the impression that the adage in media circles that bad news sells. Sometimes I get the impression that adage is more or less becoming an established truism.
But the times that we're in, what news do you think?
I'm coming. The reason why I'm saying that is that most places where they organize these elections, including my place, people followed social distancing. We sat, in fact, at least 1 meter apart. We had to use sanitizers. We used the guns, did all that, and it was across the country. But after results were declared, in the middle of the excitement, of course, once somebody is elated, for a moment, they lose consciousness about some of these things. And I've observed that the celebrations, some of the celebrations broke the protocols. But I spoke about the bad news because from day one in the morning, almost every place, we had to strictly observe all these protocols. So I was hoping that those who mentioned the celebration would have at least mentioned that most of the people across the country committed themselves to obeying the protocols until results came, and out of excitement, of course, people, and I'm not saying when you're excited, you should break the rules, but just to really appreciate all the effort that people made from morning till they saw results. And these also serve as a learning process for activities ahead, so that next time, as a country, when we are even having maybe the May election, of course, registration, nobody will start jumping at the registration center. But going into the elections, we don't only stop monitoring at the voting, but even at the declaration of results, we now intensify our alertness to everybody.
But to the extent that we've been told that if you do not wear face mask, you have there's a sanction to it, a jail term as well. We've been educated on that, but it doesn't look like anybody was picked up. And I must say, we've highlighted the good part. We observed all that, but if it got out of hand, definitely we must be highlighted. Is anyone going to be punished for this? It doesn't look like.
The last time I read or watched news, some MMDCs or municipalities were using their task force or the police to give communal punishment to people.
Yeah.
We must be committed to some form of deterrence. We must show a signal that we are serious about the protocols. That I agree.
Okay, but so it looks like nobody will be held responsible or liable for what we saw yesterday.
I've seen people who more or less interpret jail sentence to mean sanction. I think we should also appreciate the other forms of sanction, especially because having large numbers at restricted spaces only increases, like the prisons. If you throw 200 people into some prison, you are only going to add to the congestion. So we must find innovative ways to make sure that we sanction people.
Okay, that's the opening words of Dr. Bernard Okoboy. At this point, we'll go strictly into our questions that we've just received, because at the top of the hour 8, we'll be going for update number 12 from President Nana Addo Dankwa Akufo-Addo. So this one from Facebook, Emmanuel Mwakon says, why is it that after a huge number of COVID patients were discharged, in reference to WHO new discharging policy, the number of deaths also increased by 15 within 24 hours, whilst those who were on ventilators were 4? We move on to the second one, and this one from Silas Owusuchere. Please ask Dr. Okoboy, since there will be no second testing for recovery, is it the right assurance that they don't have COVID-19? So the meteoric rise in the figures when it comes to recoveries is one thing that is dominating. So they're asking about the second test, and we're told, you came here the last time and you mentioned that we're doing 2 consecutive negative tests before someone is declared as recovered, but that has changed according to the Ghana Health Service directive that was issued. Tell us about it.
Now, should I answer the question about the
you can answer the questions directly. So
the person said we had 4 on ventilators, yet the deaths that were added were about 15 or so. Just to by way of information, not all the deaths necessarily come from the ICU. So you can have an elderly person who is rushed to the hospital with coughing and has a history of cancer, and then because of the fever, you take a sample. Even before the results comes, the person is gone, but the results come positive. That is a COVID-related death. So you have deaths that are recorded that did not necessarily pass through the ICU. That's people, and most of the recent deaths we had spend less than 48 hours in the hospital. It means they come in a bad shape. You take a sample for COVID, and sometimes even before your results come, they are gone. So that's the explanation. You can have deaths. I think some assume that all the deaths will result from the critical cases, but that's not always the case. All right, now I think we have to really calm down, relax, and absorb this point, which is very crucial to appreciating what is happening. In the beginning, all of us said that this was a novel virus. We don't know much about it. It's been studied. It is the knowledge that was gathered in the beginning that informed the precautions or interventions and the guidelines. So the first guideline we were using was actually a WHO guideline about the 2 negative tests. And that WHO released somewhere in March. That was in March, I wanted to give you the exact date, but that was in March, the first protocol, the first guideline. Now, that was based on a scientific study that showed that when someone is positive today, even 3-4 weeks, you can pick a positive test. So then, the guidelines said until you get 2 negative tests. They said 2, not 1, because they want to be double sure you are not recovered. You have to get 2 negative tests. So that was the knowledge then. And then on the 27th of May, WHO now gave another guideline. And this is what led to the new guideline. And let me read samples I'll share with you. This is an article published by an author in the Bloomberg. And this is what it says. COVID-19 patients are no longer infectious after 11 days of getting sick, even though some may still test positive, according to a new study by infectious disease experts in Singapore. Now listen to this. A positive test does not equate to infectiousness or viable virus, and I'll explain. A joint research paper by Singapore's National Center for Infectious Diseases and the Academy of Medicine, Singapore. Now, let me explain simply. This is what it means. So, they studied patients who were under care and realized that they could test positive even in the 4th week. So the earlier guideline said, then let's get 2 negative tests to declare you recovered. There are 2 reasons why we keep someone who is positive. We want to monitor you and be sure that you don't get seriously ill. Or should you get ill, we intervene quickly. The second one is that we don't want you to infect someone. We assume if you are positive, you can infect. Now, this new study, what it did was that it took the blood samples of people who were COVID patients in the 3rd week or 4th week, who were positive for COVID. But this time, they cultured their blood. When we say culture, you try to grow the virus. If the virus is alive, it will multiply. You get what I'm saying? They realize that when you culture, there is no activity. So what it means is that you have a positive test, but no activity. Now, no activity means that there is no replication or shedding of the virus. And it is only those who are replicating or shedding the virus who can transfer to others. So someone asked me, how come then can you become positive? What a PCR test does, they call it nucleic acid amplification test. It picks portions of the virus, amplifies it. Once it matches the virus part, they tell you it's positive. But the fact that you've picked a part doesn't mean you have the whole organism actually alive. And it is because of this study, together with other ones which I'll share going to the program, WHO quickly reviewed their guidelines. And this is what they said. 10 days, not even 14 according to the WHO, 10 days of being asymptomatic. If you are asymptomatic for 10 days, you should be discharged. But if you are symptomatic, it is the number of days you've been symptomatic plus 3 days of being asymptomatic. Now, the study says that 11 days, you are no more contagious. But Ghana Health Service has taken 14 days to give it an allowance of 72 hours.
So these 10,000 recoveries that we've recorded, did they go through the 14 days before we've declared them all?
In fact, most of the cases we had, because of the earlier signs that we were depending on, we were keeping people for 5 weeks, even if they can do everything and they are healthy, because we were waiting to get 2 negative tests, only for the science to tell us that you can wait forever, because you continue to pick portions or remnants of the virus, but there is nothing. And so all those who have stayed for more than 2 weeks, and most importantly are asymptomatic, all fell into this category.
Okay. So all these 10,000 have been released at a go?
I think there are 2 things I'll say. All these 10,000 are asymptomatic. And based on the science, all these 10,000 are not contagious. We were keeping them because we didn't want them to infect you. The science has told us that after 14 days, in fact 11 days, we have made it 14, of being asymptomatic, they don't shed any virus. And so if you keep them in isolation, you can do that forever. And you are just depending on an old science, which further studies have, explained. And I think culture means you are growing the virus. It's different from doing a test, which is just showing a part of the virus. And I think the reason why they did the culture is that science always wants to know better. And that is what has led us to this particular guideline.
Okay, so I'm sure more questions will come up on this because we're saying it's one thing that we're touting at some point that we're doing 2 negative tests just to be sure. But based now we're not doing that based on the science. But if we have a WHO directive, what do we lose if we still go by what we were doing previously? Is it because we are running out of testing kits and all? So we'll come to that.
Sorry, the same WHO, not another organization, the same WHO which published the first guideline in March has reviewed their guidelines on the 27th of May. I have that one also, I'll share with you.
Okay.
So what we are doing now is actually going by a WHO recommendation that move from the previous knowledge and come to the advanced knowledge, which tells you that people who have been asymptomatic for more than 10 days, actually they said 10 days, do not shed the virus. Okay.
Thankfully, my other panelists are also doctors, and they will take us through the science and the data of this as well. I'll bring in Dr. Augustina Angelina Silva-King, virologist at the KCCR. She's joining us via Zoom. And then also Dr. Justice Yankson, General Secretary of the Ghana Medical Association, also joining us in our makeshift studio. And I must remind you that our radio audience have also joined us on Joy 99.7 FM. And we'll be going for update number 12 from the Jubilee House shortly. Dr. Augustina Silva-King, welcome to Beyond the Lockdown. If you can hear me, and also Dr. Justice Yankson, you're all welcome. So there were questions on the huge number of COVID patients who were being discharged, and also, but I would first want to find out from you, Dr. Augustina Silva-King, the concern is that from what we saw yesterday during the jubilation of the primaries, for instance, are we likely to see a surge in our figures?
Good evening and a warm good evening to your cherished listeners and viewers. And by the way, happy Father's Day to all fathers, especially to the presidents of the land and to my husband as well. Indeed, I mean, I saw snippets of things that went on yesterday, and definitely we should brace ourselves up for some possible spikes. Because, I mean, people were not adhering to the mitigation measures, the physical distancing, people were jubilating, people were not in nose mask. So I am very positive that we should give ourselves 14 days, which is the incubation period of the virus. I mean, chances are even that those who jubilated or those who were not in nose mask or those around, chances are that already some of them may be harboring the virus, but definitely they may be asymptomatic. It will also not be surprising that some may actually be symptomatic, but of course they needed to come out of their homes or their rooms, so they join in the jubilation. I mean, I was really worried, and I am so worried looking at events occurring yesterday. I saw people sitting in buckets of vehicles without nose masks, shouting, bundled together, and so on and so forth. And this is what the virus likes. I mean, it only wants people to be together without all the necessary protocols. And as soon as this happens, then you will find we'll see some spike.
So just gone by update number 12 from the Jubilee House. President Akufo-Addo giving us that update as the final year senior high school students prepare to go to school tomorrow together with the Go Track, second year Go Track students, over 800,000 of them were told. And he's assuring that government is determined to protect them, and that once they go, they must also adhere to all the protocols laid down. Fumigation has been done. Veronica buckets provided, sanitizers and reusable masks they will be giving, but parents must give them one as they go onwards to school. And so our cases now stands at 14,154. That's where we are, with 10,473 recoveries. We've done over 270,000 tests. Our active cases stands at 3,596, 4 on ventilators, 6 critically ill. We have 85 deaths, and the president has been speaking about stigmatization once the person has tested tested or recovered does not mean that he will still pose any danger. He's been speaking to the WHO recommendations, the new ones that have coming, that we've been speaking on this program a while ago. So no symptoms, no longer capable of infections, and we've been told about the asymptomatic. They are not likely to be infectious, therefore they may not spread the virus. These are some of the issues that we've been talking about here on Beyond the Lockdown. You've been asking questions, and with me in the studio is the Deputy Health Minister, Dr. Bernard Okuboi. Also, we have the General Secretary of the Ghana Medical Association, Dr. Justice Yankson, as well as a virologist at the Kumasi Center for Collaborative Research, Dr. Augustina Angelina Silva King. Before we went for update number 12 from the President, we were on the General Secretary of the Ghana Medical Association, and there are some nagging questions also that will be put into him. Dr. Yankson, if you can hear me at this point, this issue about persons being asymptomatic and not likely to be infectious. So I'm told Dr. Yankson is unable to hear me. We'll correct that shortly, and then we'll go to. But Dr. Silva King, you're also on. Can you hear me? Dr. Silva King would also connect to her shortly, and Dr. Bernard Okuboi is still with me in the studio. So we're getting ready to go to school tomorrow. I have a message from a colleague, for instance, who is asking that. So he didn't know that the daughter had tested positive, and she's asymptomatic. So if he had not tested her and he had gone to school, you're saying that because she's asymptomatic, she would not be able to spread the virus?
Yeah, so the answer is very simple. For those that we pick who are positive, if you are positive and you've been tested and confirmed, it will take 2 weeks of isolation before you are declared as having recovered. If you have not been tested, the assumption is that you are not positive.
Yeah.
And let's remember, I've used the term before, the iceberg principle. The confirmed test we have, you assume is the number that sits at the top. It is possible at the base you can have some who have not been picked, but that is a principle that applies universally. So in the US, they will tell you, let's say they have 3 million cases, but there are 3 million refers to those that have been tested and confirmed. If you start talking about this guy was positive, it's because I tested. What if I'm not tested? The what if applies universally, but you more or less work with what has been confirmed.
So the what if in this case I'm asking because they are going to school tomorrow. We know that the final year students and then the second year Gold Track, they are going tomorrow. But for the fact that they are tested, because they are not going to, we are not going to have a mass testing, government has mentioned. So she would have gone to school tomorrow, not knowing that she's carrying the virus, and you're saying she won't be able to spread it?
No, so there are two things. So the first one is that we've been told by the science, but a positive test does not equate to viral shedding.
Okay.
If you are positive for COVID, it doesn't mean that you are necessarily contagious. So that tells you that, well, you can pick a positive case, but thankfully it's not automatic. Then the second one, it is because there is a risk out there. That is why we mention all these plenty protocols. So that your risk, assuming that you have someone who is positive, it is because we, even from day one, everybody, we all assume there could be a risk in this studio. That's why you're wearing the shield and I'm wearing the mask. So that if you are positive and it's not been, what's the word? We've not,
I'm not.
No, let me use myself because I'm comfortable. So assuming I am positive and let's say you don't know, because you are wearing a shield, because I'm in a mask, the risk of getting it is brought down to the lowest possible. So everybody, like we said, should assume the next person is a positive case so that you take good care of yourself. That's what I have to say.
Well, let's bring in Dr. Justice Yankson at this point. It looks like we have a clear feed to him now. Dr. Yankson, so we're on you before we went to the presidency, for instance. We've been talking about how your systems are overstretched over the period, and then also how your members are, exposed to the virus because people coming and you don't know whether they are carriers of the virus. But we'll be using a lot of scientific terms tonight. This issue about you being asymptomatic and that you are not likely to be infected. So we are told that even though I'm a carrier of the virus, because you are protected or because I'm asymptomatic, we don't know if I'm not likely to be infectious to you. Is that the case? Please break it down for us.
Okay, thank you, Emefa. what the WHO is saying at this point, which the country seems to have adopted, is that, one, if you're an asymptomatic patient, then the discharge protocol says that 10 days after your positive test, you can be discharged. The assumption here is that, per the studies that the WHO and its other partners conducted, post that 10-day period for asymptomatic patients, there is only a minimal residual risk of any transmission of the disease occurring. So that is for the asymptomatic cases. Now for the symptomatic patients, the protocol as released by the WHO is saying that 10 days from the onset of symptoms is a very crucial phase. And then for such people who have the symptoms, 3 days post the resolution of symptoms, and here specifically including fever and then the respiratory symptoms. So basically what they're saying is that you have been tested positive, there's been an onset of symptoms, 10 days or any other number of days after the resolution, at some point post the 10 days, when there is resolution of the symptoms, you need to have 3 consecutive days where you are free of symptoms, including fever and the respiratory bits, i.e. the cough, the sore throat, and what have you, before you can fall under this discharge protocol without further testing. But then, the WHO has also gone on to state and given some caveats that countries should continue to do the testing where they are in a position to do it. 2, there's always a minimal residual risk that transmission could occur, for which reason the WHO is encouraging the scientific community to continue to do some more tests, some more scientific research, to come up with additional evidence to help improve this isolation discharge protocol that has come up. So baseline, the WHO has not stated categorically that nobody should do further testing. They recognize the difficulties, for which reason they are trying to balance the risk and the benefits. But they're also encouraging us that where a country is in a position to continue doing the test, the old protocol which said 2 negatives has not been thrown away completely. So basically this is what is happening.
Then interesting. So that's the concern, that then why are we as a country throwing away the 2 negatives, which we highly touted? So if there's a minimal residual risk, WHO, are we really under duress to do away with the 2 negatives when we can still continue and be sure that we are really out of the woods? I'll come to Dr. Bernard Okoboy, but I think Dr. Silver King, I'll bring you in on this one. So are we still doing the testing as we used to when we started this whole process? Okay, so it looks like I've just lost Dr. Silver King there on the phone. But let me bring in our audience. I'm doing this by myself, which I'm not supposed to. It's not about me. It's for the audience to be asking the questions. So I'm sure it will come in as we go along the line. So let's take the next batch of questions at this point.
The difference between asymptomatic patient and a recovered patient. I'm asking this because it appears government is adding up all the numbers, all the asymptomatic patients per the new health organization's protocols. They are adding asymptomatic patients to the recovered patients, and that is very dangerous because I feel going forward we may have the effects so very much on our death row.
My name is Alexander Boachi Adam. I'm calling from South Korea. I have this question that I want to ask the minister. I want to know if cabinet has taken a decision about stranded businessmen in South Korea. There are a lot of stranded businessmen in South Korea. who has been here for the past 3 to 4 months. Some of them came before the pandemic and they have been here for almost 6 months. We now don't know what the government is doing about our situation because we are stranded here. As I'm talking now, a lot of people are perching with those who are already staying here, and so many businessmen have exhausted.
So one question for Dr. Bernard Okuboy, and I'm sure this is a general one as well. Yes. The first one on the difference between a recovered patient and an asymptomatic patient, and that it looks like we are combining the two. Is that what we're doing?
Yes. So, first of all, if you get a positive test today, and the sample was taken yesterday, it is not today that you became positive, but it was yesterday.
Okay.
Now, what we are saying now, from the day you got the sample was taken to the 14th day, if you are asymptomatic during that period, you have not recovered. You are asymptomatic, but you've not elapsed the 14 days.
Okay.
So it is only when you have been asymptomatic for more than 14 days that you now are termed as recovered. Okay. So if I get my sample is taken today, COVID, and it comes today that I'm positive, it is possible that there is viral shedding. What means that I can infect you. That's why I am isolated for 2 weeks or 14 days. After the 14 days, when I come out, I'm classified as recovered. Remember, I'm not only asymptomatic, but I have been kept in isolation for 14 days. Okay. So that's the difference.
Okay. Well, and there's also a question about cabinet decision on stranded businesses in South Korea.
Yes.
Because we know about the UAE.
Yes, exactly. So the UAE, the UK, the US that we have, all came from requests like this. Government listened, and then preparations were made. So I'll communicate this to the Foreign Affairs Ministry. I'm sure if the numbers are significant, there can be a way to evacuate them as well.
Dr. Anson, do you have anything to add on the differences between the recovered and the asymptomatic? And whilst at it, though, I would want you to add the issue about whether it's a prudent decision for us as a country to abandon the 2 negative tests at a time when we are recording over 14,154 cases.
Okay, MFA, I think that we shouldn't confuse the use of the terminologies. Asymptomatic cases basically means that this is somebody who is positive for COVID, but is not showing any of the documented symptoms. So, i.e. the fever, the cough, the sore throat, and what have you. So that is what asymptomatic means. Now, this WHO criteria that has come up, it's more of a technical activity. It has to do with the discharge of patients. So here we are talking about patients who have tested positive, who are in either some isolation center or some treatment center, as you may call it, are receiving treatment. This is a guideline for us, the medics, to discharge them home at some point. Earlier, it was a test-based criteria for discharging them. Now the WHO is saying that based on the difficulties, the science, the research findings, and what have you, they think that we can have a non-test based approach to discharging patients. And that is what we are discussing. So then the WHO has classified the approach into 2. That we have those who are asymptomatic, the man has tested positive, but has never shown any symptom. For such a patient, if you have him in the isolation center, you discharge him 10 days. Ghana has chosen 14. That is the minimum the WHO gave. If the person is symptomatic, then the process is this: 10 days from the onset of the symptoms, for example. If the symptoms end, then the patient should also be free of symptoms for another 3 days whilst at the isolation center, before you can use this non-test-based approach to discharge the patient. So basically, this is what it is. We shouldn't confuse the terminologies. You may be asymptomatic, but you'll still be within the 10 to 14 days. you could be within just your first or second day. And the literature also tells us that COVID, just like some other related ones, like SARS-1, there's enough evidence to show that sometimes 3 to 4 days before even the onset of symptoms in patients who are going to show symptoms, they are able to actually transmit the virus or the disease. So basically, this is what the whole thing is about. It's more of a technical activity for the medics to use in discharging patients so that they are not kept unduly in quotes or too long at treatment centers.
So if you have the virus and you are not showing signs, which is asymptomatic, you can still go about your normal duties. Is that what it is?
No. What they are saying?
Yeah, if you have not been tested, you will never know, because you might think you are okay and you'll be moving around.
Okay.
But the policy is that
But once you are tested and you are deemed positive, then the protocol, if we are all following it properly, you go into isolation or treatment, and 10 days from the day that you tested positive, Ghana has chosen 14, which is fair. Then you get the discharge or the clear go ahead that, look, you are okay per the new criteria as published by the WHO, and then we let you go. The difference here is that hitherto you would have gone through the 2 negative tests. The WHO itself recommended 24 hours apart for this. But of course, based on practical difficulties and what have you, a lot of countries were doing a week apart, and until you got the 2 negatives, you were still kept in the treatment or isolation center. And with the delays in our testing regime and what have you, sometimes you test your first negative, it could take about 2 weeks before the second positive, negative return could be communicated formally for you to go home. So all those bits are the sort of things that the WHO looked at across the world and said that, look, we are looking at a balance between the risk and the benefits of keeping the patients there. And the risk and the balance, the benefits analysis includes the economic aspect, the health aspect, and what have you. So basically, this is where we are at this moment.
Okay. Well, I'll go into our next batch of questions, but let me bring in Dr. Silva King at this point. They are the ones who've been doing the testing. Are we testing as much as we used to do? Has our testing capacity gone down, or is still as high?
Yes, MFA. So we still receive samples, but interestingly, now we receive a lot of the so-called routine surveillance samples. So those from the hospitals, maybe people who are rushed to the hospitals or who show the signs and symptoms of the infection, and so are sent to the hospitals. It's as if the tables seem to be tested, to be changing. So we rather see a lot of such cases compared with the usual so-called enhanced contact tracing kind of samples, which means that, again, it will have a lot of implications, because if you are seeing a lot of people going to the hospital, so being classified as a routine surveillance, then chances are that people may be sitting in their homes, showing the signs and symptoms, but because of maybe stigmatization and other issues, they may not even be able to go to the hospital. So all these things, they have a lot of implications. But in terms of this adoption of the WHO discharge protocol from isolation, I am just thinking that we may want to tread them cautiously. I mean, of course, even the WHO itself indicates that there should be some level of risk assessment. And remember, as for Ghana, we've done so very well. And I don't think that the fact that the WHO says we should forget about, of course, they gave a number of reasons, i.e. lack of equipment, lack of personnel, and so on and so forth. I think we need to assess ourselves if we feel that we have the needed resources, we have enough beds within our isolation centers, and we have enough testing capacity. So we have the logistics then because look, if I am even symptomatic or asymptomatic and I am taken to an isolation center, and after a period of time I am asked to go home without any test, I think psychologically, I think we should really be treading cautiously. Of course, it is true that after this period of time, you will not find any infectious viral RNA. But even with that, there are a lot of other contradicting studies where in some cases they realize that samples taken from sputum, so sputum samples may tend to still shed some active or some infectious RNA. And even in the same WHO, the WHO document, they actually cited one study. They named, amazingly, they named it one possible outlier. So there may be some outliers whereby for this particular person in one patient, the viral cultures were positive from upper respiratory tract specimens. It continued to be positive until day 18, even though this person did not show the signs and symptoms of the infection. So I am thinking that as a country, we may want to generate our own local context-based data to enable us or to inform us on some of these discharge protocols. I mean, the WHO is our mother health organization, but I think that as a country, we also have our own uniqueness. And some of the studies they actually quoted, they have very, very limited or few number of patients, 9 patients. I mean, I'm just wondering how you can extrapolate results from nine patients. I mean, in another study, they actually included 129 patients, and they themselves concluded that in that particular study, they concluded that 30 of the patients were immunocompromised. But look, we are talking about asymptomatic patients against symptomatic patients. So I am just thinking that, I mean, now the release is already out. Yeah. I don't know if we can go back and tread cautiously, because like one of the questions, you may never know. I may appear healthy. I may not even know that I am harboring the virus, but tested, I will turn out to be positive. Yeah. And look, as our number of confirmed cases begin to go up, chances that in the midst of your friends, maybe once a group of people sits together, about 10 people, chances that some of them may be positive, though they may be asymptomatic, may gradually be increasing. In fact, chances that you yourself, you may be positive, is gradually increasing and gradually becoming a reality. I think we should kindly tread cautiously with this straight adoption of this so-called discharge protocol by the WHO.
Well, a number of things comes up for me. The lack of personnel and lack of equipment. Is this the convenience? That's why we are adopting this approach, because it's in there that if you don't have the personnel, you don't have the equipment. Is this the reason, underlying reason why we are adopting this approach?
The reported picture of the COVID situation in every country actually is close to reality when the number of tests per million is very significant. So if you take India, for example, their tests per million is about 4,934, India. Nigeria is doing 527 tests per million, 527, less than 1,000. Canada is doing 63,000. Germany and the US, they are doing close to 80,000. But Nigeria is doing 527. India is doing 4,934. Egypt is doing, in fact, Egypt is also doing around 5,000.
Per million.
Kenya is doing 2,606. Ghana is doing 8,608. I'm quoting these things. So what it tells you is that the chances of somebody walking around with the virus and not knowing is higher in countries with very low tests per million. So that nobody makes the mistake of thinking that because we are looking at people who are asymptomatic for 14 days, what if there are others around us who are positive, I don't know. That is a universal phenomenon. But the more your test per million, the clearer your picture. So ours on the African continent is one of the clearer pictures in terms of reality because of the number of tests per 1,000. Now, let me come to Dr. Silverking.
That we should tread cautiously.
Anybody who tells you to tread cautiously in science, you are not in a hurry to what's the word, dispose of the person. But this is the point I want to make. The initial guidelines released by WHO were based on studies they had done with COVID cases. In fact, most of these studies started in Wuhan, because that's where the disease broke out. Those studies were not universal studies. When I say universal studies, they were not studies that have been carried out in the hospital in China, Norway, US, and let's say Kenya.
Of course.
But because you have a novel pathogen, disease-causing organism, any minimum research you have, you want to work at least with some of the findings from that research. Now, the study I have, which has been quoted from Singapore, he mentioned a number of cases. It's true, when your cases are very few, it means maybe it's not that dependable. But this study looked at 73 patients. 73.
Not 9.
Yes. And I'm talking maybe doctor, I'm talking about the study by the Singaporeans that was released by the Academy of Science. And you can check Bloomberg. I think the date is May 24, 2020. The author is Yulin Lee. And I'll read just the beginning. It said, COVID-19 patients are no longer infectious after 11 days of getting sick, even though some may still test positive, according to a new study by infectious disease experts. Now, the paper was based on a study of 73 patients in the city-state. Now, they said it might lead to discharge protocols. I have another document by the Europe Center for Disease Prevention and Control, a technical report on novel coronavirus, discharge criteria for confirmed COVID-19 cases, when it is safe to discharge COVID-19 cases from the hospital or home. Now, there's a paragraph that is interesting, and let me read. Prolonged viral shedding from nasopharyngeal aspirates up to at least 24 days after symptom onset was reported among COVID-19 patients in Singapore. Researchers from Germany also reported prolonged viral shedding with high sputum viral load after recovery in a convalescent patient. They acknowledge, however, that viability of SARS-CoV-2 virus detected by qRT-PCR in this patient has not been proven by viral culture. Now, I want to explain in simple terms. What they are trying to say is that they acknowledge that in some patients, even for a long period, you can pick a positive test. What has not been confirmed or done is the culturing. And I've explained that a culture actually grows the virus to tell you of its shedding and, for that matter, its contagiousness. A positive test, it's an amplification test, and Doc knows better than me. So this is the point I want to make.
So this second one that you're talking about, how many persons did it say? Because 73 persons, for instance, is it enough?
No. Most of the tests that we are doing, we are not using, let's say, 300 people. Okay. This is not like, it's not like, how do you call it, it's not a study that you just go into the population. You are using people who are ill because you might have them in a particular number. Look, our ICU in University of Ghana Medical Center, 5 beds. We are now working to 16. So it's not a typical case like maybe malaria where you can get numbers in the hundreds. But the point I want to make is that at any point in time, you are only working with some experiments or studies that have been done in some parts of the world. Because it's a novel virus, you've not gotten to the stage where you might get maybe a plethora of, how do you call it, studies to strike an average and choose from. Look at an example. An example is the use of hydroxychloroquine. It was based on a research that was happening in France. They started on their own. Well, and people started, but later, the same people said they are not too sure about, how do you call it, the benefits of the use. And so in some countries, they withdrew it. It's just to make the point that at the time, almost all of us were going with hydroxychloroquine. It's not that the tests were carried out across the world, but 1 or 2 places.
No, but have we independently, for instance, as a country, engaging in any kind of research, for instance, to see what suits us?
Absolutely.
Is it that it comes and then we just go? What do we lose if we maintain what we are doing?
No, in fact, I have talked to people in the case management team, and they have indicated that they also have a couple of studies going on.
Okay.
In fact, some of them actually confirmed that the new evidence from Singapore more or less, more or less confirms what they've also observed with patients who have been within their isolation centers. That more often than not, when you text them after 14 days, you are likely, or you usually get a negative test. Now, I think what I must add is that there is a difference between testing someone for SARS-CoV-2 and doing a culture to grow the virus.
So a couple of studies, it means that they are not conclusive at any point in time.
The earlier guidelines, which, forgive me if I use this term, which let's say you were comfortable with, were based on a couple of studies.
I'm not comfortable with it. The government touted it that this is what they do to ensure that we do not spread the virus. That's what you said.
It's very simple. Science can evolve. You work with current knowledge. And I've explained to you that it's because test was done in some people 3-4 weeks later. They were positive. And based on that, we said we are going to keep you for as long as you are positive.
Okay.
Only to be told that being positive does not always translate into what? Being infective. And that viral shedding or activity usually vanishes by the 14th day. In fact, WHO said 10th day. We have added 3 more days to be on the safer side.
Well, I know Dr. Silver King is itching to coming at this point on this. The virus is novel, so we need to deal with current information, science, and data to deal with our situation. You agree?
Absolutely, MFA. And interestingly, I have the same technical report. And for quite a number of the studies, the authors themselves even raised some level of concern about the fact that patients were discharged from hospitals based on negative outcome of their test. The point I'm making is that we need to tread cautiously. And I'm just thinking that maybe the prudent thing we may want to do is to generate our own data. And I think we already have the data. I mean, for us, we may not be able to culture the virus because we may not have the necessary platforms or resources. You may need a biosafety level 4 at least to culture the virus. I mean, the WHO itself even says that you need biosafety level 3. But then this is a novel virus with no known medication. So usually you classify it as a biosafety level 4. So maybe the best thing we may want to do is to collaborate and also generate our own data, localized data, context specific, so that we can stand on our data and then make all the necessary protocols and policies we want to. I am not disputing the fact that we may have challenges with our isolation centers and so on and so forth. But the important thing is that I think we need to tread cautiously. And the point is the fact that WHO wants us to do it doesn't mean that we are really obliged. And the WHO itself indicated that, look, you may still want to follow the initial protocol, and I think we should really be very cautious because look, if we don't take care, our citizens, they may even end up trivializing this thing because look, they get up one morning and they see this huge number of recoveries. Now in their minds, people will be like, oh, of course, I mean, people get it and they even recover. Just go to the isolation center, rest for a period of time, and then come back home and continue your daily routines. So I think we need to be very, very, very cautious.
Okay, let's go for the next batch of questions at this point. Dr. Yankson, I'll come to you. I'm sure there are questions that will come up that would be able to go around, and then we can give answers. I'm also getting a lot of education, medical education this evening on Beyond the Lockdown. Let's go for the next batch of questions. Are we ready for the next batch of questions on Facebook, on WhatsApp? You've been sending, you're getting interactive. So this one on WhatsApp says, please, my question is, what are the guidelines for the students when they are out of school? Do parents need to quarantine them for 14 days? That's those going back to school from tomorrow. That's the question. I'll rectify that. We'll go for more of your questions shortly. I'll also go live on Facebook. You've been sending on WhatsApp as well. So this question, I'm sure any of you can take. Do you want to take that, or do we go to Dr. Justice Yankson? Is there a question you want to take, or Dr. Okoboy should take it?
Now, if the kids come from school, why do you want to quarantine them for 14 days? It's not like they've been exposed to the virus for being in school.
You are not testing them. You are not testing the teachers. So they are going to school for 6 weeks, write exams, and comes back.
But I've come to multimedia. Forgive me, but I read that some of your staff are positive.
Of course.
When I leave here, should I quarantine myself from my family for 14 days? The point is that once you have a virus in the global population, anywhere you go, the assumption is that there's a measure of risk.
Okay.
Just that the risk can be higher in some environments than others. Of course, the risk in a hospital environment is assumed to be higher than in a multimedia studio. So it's not like the schools are some peculiar place where if kids come from, they need isolation.
Okay.
In fact, maybe they are even better placed because they have been confined to an area compared to we who move in the larger or in the bigger space. So I think basically what I'll say is that when they come back, they don't need any.
So the assurance is that even though they are not being tested whilst they are there,
but those at
during
home,
the period, they cannot pick up the virus.
What about we, those at home? Are we all being tested on a mass scale? No. So
but they are going to be confined in the same environment.
My point is that they have been confined within a secondary school environment.
Yes.
I have been confined within the greater Accra environment.
No, but
you don't get it. When I'm using a boundary so that you get a picture. I am in a bigger code. And because I get exposed to different environment, really my risk is even greater than they who are within an environment with not many varied points. I go to, in my environment, I can enter commercial vehicles, I enter markets, I go on the streets, I enter offices. So the more varied the environment you are transiting, the greater your risk. So they who are in the confined environment, theirs is better. And remember, we those in this environment, it's also possible that you can have some positive cases out there.
Yeah.
Some talk as if, what if one student is positive, nobody knows? What about a greater population? What if 10 are positive? So we should not try to use the, in quote, unknown, the assumption of the unknown cases to try and say that a particular environment is contagious or not.
Okay, we'll quickly go into the next batch of questions at this point. I'm sure we're ready with them. WhatsApp, okay, so on Facebook. So this one is coming up. So it's from Abdullah Sofo Kabiru. He says, please, I want to know whether or not our frontline workers at UGMC Intensive Care Unit still enjoying their free daily meals as arranged during the beginning of the pandemic. And this one for Dr. Augustina. You've been very instrumental in testing for COVID-19 cases since you are my lecturer. I want to know how these COVID-19 cases are being tested since everyone is out there doing his or her own thing. Does it mean people are submitting themselves to be tested? Somewhere late May, we heard we were at the peak of the outbreak. How true is that, and what accounted for the swift increase in COVID cases and abrupt recoveries? Ordinary Ghanaians are becoming increasingly less likely to believe in the existence of COVID-19 in Ghana. Kindly brief us. That's from Teddy Ben. And Stephen Lebene Kumsin says, I remember an app was introduced to aid the fight of COVID-19. I want the Deputy Minister of Health to explain to us, 1, how many positive cases was the app able to register? 2, how efficient is the app in contact tracing, and how many contact tracing has been done by the use of the app? And was the app useful to us or just a means to waste our data? Stephen Lebene Kumsin sent that one. And then Camille Dasana says, please, Ghanaians stranded in Saudi Arabia are also waiting for evacuation. Ghana is our motherland. All of us are citizens, please. And then this one from Abigail. It says, Deputy Minister, I heard this evening of some massive recoveries, whilst in fact they were not recoveries, but those who have been discharged without further testing to determine their status. So that's what we've been talking about for this period. So we'll go for questions and responses to these questions at this point. Dr. Silver King, I'll start with you. So there's a question from your student to you on the issues about testing that he's been asking.
that we use the polymerase chain reaction, the quantitative PCR to detect the presence of the viral RNA in suspected cases. So they typically have a case definition, and then once a suspected case fits into the case definition, the sample is taken. So the sample could be the sputum, the nasopharyngeal swab, oropharyngeal swab. We also use nasal washes. They are sent to the lab. We isolate the viral RNA, and then we perform the polymerase chain reaction. Typically, we target there are two areas on the viral RNA we target. So then once you are done, you'll be able to know whether the sample is positive or negative. I've explained it in very simple terms, but this can take you between 6 to 8 hours, depending on the type of specimen you have received. So if you receive something like sputum, then we know sputum is mucoid, so you have to treat it. And remember, this is a novel virus, so you can't just put it on any table and work on it. So you need specialized laboratory containment to enable you perform the various tests. So in brief, this is what we do in the lab.
And briefly, he asked the issue about peaking, that some time ago we're told that we had peaked, and what happened?
I think it had to do with the number of accumulated positive cases observed within a period of time. Remember that I don't know whether we have still been able to calculate that very important parameter or variable known as the R0, which tends to inform us about the potential number of people one person can transmit the virus to. I don't think we still have such a parameter. These things are always very, very, very important. So that once you know this so-called R0 or this R0, you'll be able to at any point in time predict the rate at which the virus will get into your population. And I know that some time back we heard that the Ghana Academy of Arts and Sciences were asked to put together a group to do modeling or to model some few things. I'm positive they are done with their model, and we always need these things. We need the data to inform us, so they can do a whole lot of predictions with such models. I don't model, but I know that, for example, they use the number of susceptible cases, the number of infected cases, those who will recover, and unfortunately those who will die, for example. And they can even, at the end of the day, model the impact of your mitigation measures. So, for example, if 10% of your population are wearing the nose mask, just wear a nose mask, how will it translate, or how will it have an effect on the number of cases you see on daily basis? So these things are some way, somehow not so very much evident within our country. And we expect that if we know them, they need to be made public, so that at every point in time, we will all be able to, comply to the safety measures. And remember that I think in the 10th or 9th speech of the president, he indicated that we are currently at stage 1, for example, or phase 1. I honestly don't know what will propel us or make us graduate from stage 1 to stage 2. I'm positive that all these, those who are into project management, they call them, benchmarks? So if it's, for example, a simple check box, if we realize that 70% of our population, they're actually adhering to the safety measures, then we take it. We know that at the end of the day, if we have 50% the items on our checklist, we have been able to achieve 50% of them, then maybe we can move to stage 2. But it's as if we don't have some of these indicators. I also don't know what will, for example, make us stagnate at phase 1 or stage 1. Or unfortunately, what will even trigger an unusual situation where we may move from stage 1 to stage 0.
Okay.
I'm very positive that some of these things are there, just that maybe they haven't been made public.
We have to take more responses to more questions, Dr. Silva King. We need to take more questions, and then we can get more responses to them. A number of questions still outstanding. I'll come to you, Dr. Bernard Okuboy, because there are 3 more questions for you, but I want to go to Dr. Justice Yankson. So we've been talking about infections amongst your members. For instance, at the last count, we came up to over 70 of our doctors being infected in the front line. What's the situation now as we speak? I'm sure cumulatively you still have some numbers in terms of what is being done. You had also raised concerns about testing results not coming in quickly for you to be able to deal with the cases that faces you on the front line.
Well, MFA, just like the president mentioned, we've actually lost one of our colleagues who was a pediatrician in Kumasi, a young, medical doctor, very vibrant, and it's unfortunate. May he so rest in perfect peace. Truth is that frontline health workers have been exposed within this period. Some have been able to go through the treatment phase without loss of life, but unfortunately we have also lost some senior people, middle level. So clearly this is a problem. It is not limited to doctors only. Nurses have actually been infected, other workers within the health space, so the non-core medical staff who help us on the wards, in the theaters, the cleaners, what have you. People have been infected. So clearly, we are facing the brunt of what COVID-19 has presented to the world. But then, the major problem we always have has to do with the protection for the health professionals. Yes, government has done some activity by supplying us with PPEs and what have you, but truth is that it is not enough. We need a lot more, because most of these PPEs are single-use items, and depending on the level of activity in a particular health facility, you could consume whatever is supplied within a very limited period. So if the decision or the thinking is that, oh, I have given, for example, 1,000, it could be misleading, because that 1,000, yes, you have given, but the use is such that that 1,000 probably didn't last a week or 3 days or 5 days. And he's taking more than that period to bring in some more. So the supply of PPEs is very, very important. General infection prevention control measures will have to be stepped up in all the health facilities. This is a must. We have no option. The problem with the testing is still with us. At some point, Ghana Health Service promised us that we were going to be able to have results real time, i.e. within 24 hours. But based on the practical difficulties on the ground, there are instances where the earliest you could get your results averagely will be 48 to 72 hours. The problem we have is that when you have a suspected case on the ward, for example, there are other patients on the ward. If the results should take too long in getting back to the doctor, then what happens is that there's a higher risk of patients on the ward being infected, or the healthcare givers themselves, doctors, nurses, laboratory practitioners who come into contact with these patients will then have the unfortunate event of potentially getting infected because of the long interactions with such patients. And when the results are not in, sometimes you cannot be clad in full PPE as if you are in the treatment center proper. And these are the problems that are sort of leading to frontline health workers getting exposed virtually all over the place, and the disease burden on us generally is beginning to take a toll. on us in terms of what we do at the health facilities.
So, Dr. Okoboye, there was a question also about the UGMC. Since we're talking about the health facilities, why the free food, whether it has ended, whether it has stopped, it's not coming. And then the COVID app, they were asking about how many cases this app has been able to detect and contact tracing, and then those in Saudi Arabia. I'm sure that you have spoken to already.
I think since today's discussion, the trust is on this new policy, and more or less the recovery definition. I wanted to, especially for the sake of your viewers, read just one paragraph of the clinical management of COVID-19 cases, interim guidance, 27th May 2020 by WHO, the World Health Organization. Just so that viewers appreciate the fact that what this country is doing is not a subjective arrangement where we, as an isolated case, but it's a recommendation from the world's body that gives guidance on health.
Of course, you've established that point.
Yeah. I just wanted to, it's important. Now, this what the first highlight is that, though not intended to be an exhaustive list, the following bullets highlight some key changes. 1, discontinue transmission-based precautions, into bracket, including isolation. Discontinue, that's to discharge, more or less. And release from COVID-19 care pathway for symptomatic patients 10 days after symptom onset, plus at least 3 days without symptoms, without fever and respiratory symptoms.
So that's 13 days.
Yes. So that's for the symptomatic. It's the asymptomatic that they say 13 days without symptoms. Now, I say this so that we all realize that as a global community, and the president mentioned some countries, in the EU, discharge protocols have been reviewed and changed because of this evidence. And he mentioned countries like Dubai, Hong Kong, and all that. I just wanted to mention so that we know that it's not like because we don't want to do 2 tests. And I think it's important also to let our viewers understand that doing a test, there must be a reason for a test. If a positive test does not tell you about viability or contagiousness, then I'm sorry, if you continue to do it, the value might be very minimal or non-existent. And that this is a point that must also be clearly be put out, that maybe, or let me put it this way, finding the money and resources might not be the problem. But if the value, what it tells us, is not what we want, or it will not impact on our intervention, then you have to really look at, take a second look at it.
Okay.
I think most Ghanaians thought if you are positive, it means you can give to your brother. But the science has taught us that a positive test does not necessarily translate into contagiousness.
Okay.
Now, about the doctors, I mean the health personnel, let me say that, again, exposure is a scientific term. But some, forgive me, some laymen, when they hear that medical personnel have been exposed to the virus, they think that the personnel are without protective gear, and then like the virus gets to them. When we say exposure, we only mean that there is a virus in the population or risk in the environment, and then you contract the disease. So you can be well gowned, adequately prepared, but once you get it, you might have been exposed to it before you get it, even if you are, what's the word, well gowned. So the term exposure only tells us that there is a virus, a risk in the environment, and the doctor got it, so that people don't think the doctor was working without any protection. Now, the second point I want to make is that.
But how do you contract it if you are in all the protective?
You can ask them.
Okay.
There are people who work in the labs. A doctor is a virologist. You can be all well dressed, working in the lab, and still contract a virus. What it means is that the strict things you have to go through, there might be the slightest breach. And that's why even we are taught how to.
So if I'm wearing the face shield now,
yes.
I could still be exposed to it. Is that what you're saying?
It reduces your risk. But wearing this gown doesn't mean you never get COVID.
You never get it.
Yes.
So if I wear it every day,
yes,
I can still.
You see, it's all about risk measurement. I think we should get this. No arrangement puts you at 0 risk.
Okay.
There's a difference between risk reduction behavior and risk avoidance.
Okay.
So that these things we do, my mask, my washing hands, is to limit and reduce my risk to the barest minimum.
Okay.
But it doesn't mean when I do these things,
100%.
I can never get COVID-19.
Okay.
I think we must get that clearly.
All right.
Now, we as a government are committed to sustaining the supply chain. And I always talk about supply chain because most of the things, like Dr. Yancey said, are consumables. You use, you discard. So you need a very strong monitoring system. We are using both IT, manual monitoring, to make sure that when PPEs are falling below adequate levels, they are replenished. I got a call from a doctor in Kumasi who told me that they've sent a patient to the emergency, a doctor, and that they are saying, the doctor said they don't have PPEs, so they can't take the patient. I said, how can it be? So I called the CEO, and the CEO said, I've talked to the head, they have all the PPEs. Then I called this doctor back, give me the name of the patient. The name wasn't coming forth. I said, you said the patient has not been absorbed. I said, no, the patient is already on the ward. But when we want to go and visit, they said there's no goggles. Then I called back, they said they have goggles. So sometimes also, forgive me, sometimes the hearsay or the reports we get, some of them are not too accurate, and they have a way of poisoning that was here.
Now let's go into the specific questions that were put out. We have limited time. We should be wrapping up. So this talked about the frontline UGMC. They were supposed to be giving something. That is not coming.
I was at UGMC some few days ago, and the CEO mentioned that they had an arrangement. They give free meals and all that, but they are working on some resources from the COVID fund to make sure that some of these things are available all the time. From the time he talked to me till now, whether it's been restored or not, I have to check from. But I know they have.
Why did it stop?
I can't tell whether it stopped. But he told me that to sustain that arrangement of free meals, they needed some resources which they were working on.
Okay. So the COVID app is asking how many cases you've been able to help track?
I mean, the case management people let me understand that. The app has also contributed to our tracing arrangement and all that. But in terms of disaggregated figures, to tell which were due to the app and which were due to manual tracing, I don't have that information now.
Okay, well, but that's an information you can get us later on. So I have some questions also on WhatsApp at this point, and this one is asking, please kindly give us update on KNUST COVID-19 test kits. We really need it this time when restrictions are beginning to be eased. Dr. Silva King, do we know the update on the COVID test kits from the KNUST?
So I don't really understand the question. I don't know whether...
So there was the test kits, the test kits that was developed some time ago from the KNUST. I don't know if you updated on that. We told they had gone to the FDA. So where are we with it?
Yes, the rapid diagnostic test. So the CEO of INCAS, I communicated with him. He told me that he has received the reports from the FDA. So he's working on the reports, and hopefully it will be accepted, because I think it will be very, very relevant for us, especially this time where we know that PCR is expensive, and I agree with you that it is expensive. You need a lot of expertise. You need people, highly skilled people to perform the test. So let's see how the next few days go. Maybe we will get up one day and get to know that the RDT is ready, and we can all gladly use it. Okay, so
we need to be wrapping up. I'm surprised at how fast the time has just gone, but I'll just play this video on the face mask. We're told that people are not adhering to it. Let's quickly take that, and then I'll come back for your final comments.
According to Bible, no, Exodus 7:15, no, me read the Bible, and I'm in
I believe I cannot be infected because the Bible says disease cannot be transferred. The safety measures cannot work for me.
Comply very well by putting on my face mask, having hand sanitizers and stuff. I don't believe face masks should be worn just while walking on the street at all times. Face masks should be worn only or mostly when you're interacting with people, when you're about to board a vehicle, and well, you can't stand alone and put a face mask.
So you must know that it is mandatory to wear a face mask, a face shield, or a nose mask. If you are not wearing it, you just heard the president. The police will be enforcing the sanctions, and you need to wear your face mask. So I'll take a final comments at this point. I'm so surprised at how fast the time has just gone. Many of your questions. Dr. Yankson, so the theme for tonight is the increasing COVID-19 cases. Is it a fight that we are winning from where you sit?
Let me just say these two quick things. One, this topic that we've discussed about the discharge, the same WHO report gives us some caveats. And I think we should bear that in mind. It says that there's minimal residual risk that transmission could occur within this non-test-based criteria. So we should not forget about that. The WHO itself is also encouraging the scientific community to compile a lot more evidence to help improve this isolation discharge protocol. It is also encouraging countries to continue to test, and has also said that countries can still go by the original discharge approach where you had 2 negatives. What this means is that the WHO itself is saying that, look, this new approach might not be absolute, for which reason we should tread cautiously, as Dr. Silverkin said. We should bear these caveats in mind. A quick one on the PPEs. Yes, Dr. Koboy was right. The PPEs will not say that if you use it, it means it prevents every single risk. No. But there are some qualities that we need to observe. One is the appropriateness of the PPE at the particular point. If you're a health professional and you don't have the right caliber of PPEs, the risk levels will go up.
Higher.
It should be fit for purpose. So it is not just a question of making them available, but it should be made available, and it should be fit for purpose, and it should be of the right quality. That, together with other measures within the bigger infection prevention control space, is what generally limits the risk of health professionals contracting it to the highest levels that you could get. And these are some of the things that we are faced with as challenges.
Dr.
But let me go back quickly to your question you posed.
Briefly.
The rising cases, yes. You see, we are worried about the rising case count, not just the figures, but especially the daily weights that are churned out. What it tells us that there's significant community spread, and unfortunately, some of our brothers and sisters, just like you saw in the video, are not even practicing what we have asked them to do by way of the preventive etiquette. And until we are able to get a lot more people to do that, we run a higher risk as a country when it comes to the fight against COVID-19.
Okay, Dr. Yankson, thank you so much. Dr. Silverking, are we winning this fight briefly?
MFA, I keep on saying that, look, as for COVID-19, when it comes to how it accelerates, it does it quickly. But when it comes to how it decelerates, it goes down. It is slowly, which means that we need a lot of uncomfortable mitigation measures, yet very, very simple measures. Sometimes in the evenings, I'm sure people assume that the virus goes to sleep, because as for the evenings, people don't adhere to anything. You see people walking about in wearing nothing. They are just chatting, moving in groups. And I think that we, again, on the WHO protocols, we need to chart our own path. If we put our forces together, I'm positive we will be able to slow the rate at which the virus is moving.
You have a hold on the virus?
However, let me say that we still would make sure that as a country, like the president said, our interventions will be guided by scientific evidence or work. And it is because we, as a country, know that the virus is a novel one, and that no knowledge is absolute. That's why in the face of all this, we encourage people to make sure that we stick to the protocols. I mean, this is a country that is investing millions into face masks for all students, sanitizers, Veronica buckets. Why are we doing all this? We are finding ways to reduce the risk to the barest minimum. It cannot be done only by the government. We all should play our role. we shouldn't get to the place where we want the police or the soldier to tell us that our life should be guarded. It should be guarded by ourselves.
Okay, I can't have you without asking how the health minister is doing. Your minister, how is he doing?
He's very fine. I'm sure this week or next week he'll come back to work.
Okay, so he didn't get to go through the 2 negative tests.
No, I think this policy was just adopted. So I think he falls within the batch that actually tested negative before going home. But like I said, in the face of new evidence, we've reviewed the policy. And I believe strongly that in the absence of a vaccine and definite treatment, what can save all of us globally and in Ghana is to stick to the protocols.
So you work closely with him. Have you had cause to test, for instance?
But before asking this question, you moved. Yeah,
yes, I
tested negative when they tested the MPs, and after his positive test, I also tested negative.
Again. Okay,
negative.
Well, good for
Yes.
you. And that's it for tonight's edition of the Beyond the Lockdown. My guests have been the Deputy Minister of Health, Dr. Bernard Okoboy, of course, the General Secretary of the Ghana Medical Association, Dr. Justice Yankson, and Dr. Augustina Angelina Silver King is a virologist at the KCCR. Thanks so much for your company. At this point, I can safely say that I've been schooled on medicine here on Beyond the Lockdown. You can say same too. There's more news when you log on to myjoyonline.com. I am MFA Pau. Another Sunday edition of Beyond the Lockdown will come your way. Keep watching Joy News, free to air on all your digital platforms. Have a good evening.